Good afternoon, everyone, and welcome to our webinar. My name is Scott Allen. I am the CEO for the Family Medicine Education Consortium, and I'm happy to welcome you to this first of 5 webinars about young breast cancer survivorship. Today, we are going to tackle Module 1 from Oncology to Primary Care, Building the Foundation for Survivorship Support. So I'll just give a couple quick intro comments and then turn it over to our presenters. Next slide, please. So this work is part of a 5-year grant agreement with the National Association of Chronic Disease Directors and the CDC. We started last year with some planning, talking about how primary care can better support young breast cancer survivors. And we are launching the educational components now. There is a residency training presentation with a facilitator guide, slides, speaker notes, activities, which we encourage you to adapt and use in your program. And there's information on our website about how to do that. This is a 5-part webinar series, and we're fortunate to be working with some experts in breast cancer survivorship to help you primary care providers and family physicians understand how you can support those patients. And then we will be launching a quality improvement project later this fall. So if your clinic or residency program is interested in participating in that, make sure to connect with us, and we will be sending that out by email. So next slide. And just a quick disclosure, we have filed for CME credit. We expect to have approval soon. You will all receive a certificate for that once that credit is approved. And just the financial support statement here about this being supported by the CDC via the National Association of Chronic Disease Directors. And we, the Family Medicine Education Consortium, really appreciate all the support and guidance that they're giving to this project. So with that, I'm going to turn it over to our first presenter, Dr. Lucking.
Hi there. So my name is Dr. Sara Marian Lucking. I am a dermatologist by trade. I'm also an inflammatory breast cancer survivor and advocate. I was diagnosed with inflammatory breast cancer at the age of 37 when I was 3 months postpartum and breastfeeding. Since that time, I have created a wellness resource website called Health Through Cancer, as well as founded a regional nonprofit cancer survivor community called Better Together Survivors.
Hey everyone, my name is Shanthi Sivendran. I am a medical oncologist, a clinical associate professor at Penn Medicine at Lancaster General Health. In my role over the past 15 years, I've had the honor of treating many patients with breast cancer. I'm also the Senior Vice President for Cancer Treatment Support at the American Cancer Society, and in that role, I build programs to meet the needs of our patients, caregivers, and healthcare professionals in advancing post-diagnostic care. So thank you for having us here today, and we're really excited to work with all of you. So Dr. Lucking, I'll send it back to you.
Thanks. All right, so we're going to get started here. So we have no relevant financial disclosures, and we will not be discussing anything off-label or investigational uses at this time. Our objectives for the first module, we're going to define early onset breast cancer, discuss diagnostic pitfalls, different characteristics about the tumor, recognize why it's frequently diagnosed at more advanced stages, and presents unique diagnostic challenges in which populations are disproportionately affected. We're also going to take you through a patient's cancer journey from an oncology standpoint, treatment-related side effects, and the impact on survivorship and maintenance stage, and explain how age, life stage, family responsibility, finances, fertility, psychosocial stressors all are going to influence treatment decision and survivorship. And the most important part is, what is the role of the family physician throughout this cancer care continuum for young breast cancer patients? So let's add a few definitions to this because that's important. In cancer, a person is considered to be a survivor from the time of diagnosis until the end of life. And so sometimes we talk about survivorship, and I want to make sure that when we say survivor, we're also talking about those with active treatment, maintenance treatment, and ladies who are on treatment for metastatic disease. So we know that the survivor population is increasing, and 1 in 8 women will get breast cancer. So let us think about that. That is a staggering statistic. There are 18.6 million cancer survivors in the US, and this number is expected to grow to 26 million in the next 4 years. Breast cancer survivors represent 22% of cancer survivors in the US, And there's an increasing number of patients diagnosed with metastatic breast cancer and those on maintenance therapy. So what does this mean for you as a clinician? What does this mean for your practice? It means that there is an increasing number of patients living long after diagnosis, especially those that are younger at diagnosis, and that the skills and knowledge and resources are invaluable. And they're not just for your young breast cancer patients, but they're also for all patients diagnosed with cancer that you serve in your practice. And what we're seeing now is that cancer survivorship care is now an essential skill in family medicine. So what does that look like? So we created this family physician continuity across the cancer journey. So there's many different aspects where the family physician, as a lifelong comprehensive care provider, is going to be touching on the cancer patient. So first and foremost, we need to look at prevention and risk. So counseling on preventative measures and self-awareness and screening for high risk and what that looks like. Then it is early recognition. And I think one thing I want you all to take home with you is that there is no patient who is too young to have breast cancer. And because of the aggressive nature and the higher risk of mortality from it, a timely evaluation and diagnosis referral is so important. And you're really at the forefront of that, even before the oncologist takes over. Additionally, we know that lifestyle medicine is important, as you already know, for all of your patients, but it's especially important for cancer patients. Nutrition, exercise, mental health, sexual health, all of these things are needs that the cancer patient has, but they're really important in preventing recurrence, improving quality of life, and improving outcomes. And it doesn't just happen after the active treatment after the active treatment is completed. This can happen at any point. Additionally, there is co-management of complex care. So working with the oncology team, because we know that a lot of the medications that cancer patients are given has significant side effects, and co-managing things like diabetes, hypertension, depression, anxiety, sleep disorders, and most importantly is immunocompromised state from time to time. So that's going to be a really important aspect as well. And then realizing that the family physician does care for the whole family. So supporting caregivers and family members, realizing that whenever a patient is diagnosed, it affects everyone in her family, her community, and how to support those that are in your practice as well. And know that young breast cancer patients are more likely to have a hereditary risk, and that's going to affect maybe their children, their siblings, but it does affect the family. And then long into survivorship or maintenance therapy, how to help monitor for recurrence, manage long-term side effects, and be the bridge to ongoing care. So this is a lot. We're not going to do this all today, right? This is a 5-module series. We're going to give you tools to make this more manageable and accessible. That is our goal. So what is early onset breast cancer? So this is a little tricky. There is no universal definition of young versus early onset breast cancer across organizations that is standardized. So some may say young breast cancer, and this would be under the age of 40. This is commonly used in oncology literature and clinical practice. And for some support groups, they do make this distinction as well. But I also want us to look at this early onset breast cancer, which is before the age of 50. And this is used in a lot of research. And the reason that this is important, this under the age of 50, is that often the common struggles are there. Early medication-induced menopause, different transitions in life, and just a different awareness and mindset of life. So 20% of breast cancers are diagnosed in women under the age of 50, 10% under the age of 45, and 4% under the age of 40. And the incidence is increasing faster in women under the age of 50. So we're seeing more of it in the population. And what this means is that there's a lower survival for younger women who are diagnosed at a younger age. What I want you to take away from that is age cutoff helps us define the populations for research, but clinically, in patients younger than 50, this age requires attention. Patients have unique psychosocial issues, and the treatment can cause medically induced early menopause, genetic issues, diagnostic pitfalls, intense treatment, and long-lasting side effects. And that is why the population is unique. So looking at that a little bit more in detail, let's look at delayed detection. So we know that there's no effective screening test for women under the age of 40. Guidelines are to start mammograms for a normal risk person at age of 40. And so the American College of Radiology recommends risk assessment starting by the age of 25. So I think that's really important. And then let's look at this number that I've highlighted. 80% of young breast cancer is self-detected. And the other interesting information here is that patients younger than 18 to 39 are more likely to ignore the symptoms. So not only are these patients finding it, they're more likely to be maybe too busy or not think that it can happen to them because they're not old enough. But what we know is that when young breast cancer patients present, it's at an advanced stage, larger tumors, more nodal involvement, and more often to be metastatic. Also, the biology is different, more aggressive subtypes, more triple negative, or HER2 positive or hormone receptor negative. And we think about, negative receptors, that means fewer targets. Also, more likely to be higher grade proliferation and more likely to have hereditary mutations. So we know that early detection matters. Detecting breast cancer earlier expands treatment options, improves quality of life, and increases long-term survival. So you are all at the forefront of that. But let's look at what early detection looks like for young breast cancer patients. 2/3 of patients 40 years of age or younger have regional or distance cancer at diagnosis, compared to 1/3 of patients who are over 40 years of age. And so we know, looking at the early versus late stage, there's decreased survival. And so this is something that needs to be addressed. One way to address that is, what can we use to screen for high risk? And no tool is perfect. We all know this. But these are two models that are widely used that can be very helpful when you have your patient who's 25 presenting to you in your practice. And how do I screen them to see if they are at high risk for breast cancer? These are going to take into consideration things like age, height, weight, menstrual period, but it also does take into account personal and family history. And sometimes patients don't know their family history or don't know it fully, or they may only have a few first-degree relatives. So that's why you really have to find a screening tool that you feel comfortable with and use it to the best of your ability. So when you look at specific populations, I just wanted to make sure that we're all aware of this. Persons of color tend to be diagnosed at a younger age, a later stage, and have a worse prognosis. This is a staggering statistic. Black women have a 5% lower breast cancer incidence than white women, but have a 38% higher breast cancer mortality. Young Black women are more likely to get triple negative breast cancer, 2 times more likely to die from breast cancer. Hispanic and Latina women are more likely to be diagnosed before the age of 50 and with advanced disease and have a higher prevalence of HER2 positive. American Indian and Alaska Native women have a 10% lower breast cancer incidence and a 6% higher mortality. So what are the potential causes? We don't know all of the causes for sure. May possibly be access to insurance, preventative care, timely diagnosis, high quality treatment. And there may be differences in tumor biology across racial and ethnic groups. And indeed there are, but I feel like we probably don't understand fully what this entails. And that is partially because persons of color tend to be underrepresented in clinical research trials. And then there's the aspect of lifestyle and environmental factors. There may be decreased access to healthy foods, opportunities for physical activity, and a shift away from traditional dietary patterns after immigration or acculturation, which may influence this risk of breast cancer. And this is a schematic just showing this more graphically, how the mortality rate is disproportionate to the incidence rate, depending on the specific race and ethnic group that we're looking at. One more group that I wanted to specifically focus on is pregnancy-associated breast cancer. And this is because as a family provider, you are caring for the entire family. You're caring for patients throughout their pregnancies. And I want you to be aware that, as you know, breast cancer can occur in pregnancy. It occurs in approximately 1 in 3,000 pregnancies. 30% of breast cancer in women under the age of 45 occurs within 5 years of pregnancy, and we call that pregnancy-associated breast cancer. And we know that women diagnosed in this stage of life have a higher risk of distant metastasis at diagnosis, a higher risk of recurrence, and a lower overall survival. And you are definitely at the forefront of detecting this and also, making your patients aware and then saying that, you can get breast cancer in pregnancy, in lactation, in these periods. So I'm going to turn this over now to Dr. Sivendran, where she's going to take over from an oncology standpoint, the patient's journey.
Thank you, Dr. Lucking. So as I think through, I was thinking, as we were putting together this series of talks, why, we know that survivorship and good survivorship care is important. But in order to really understand how best to serve our patients in survivorship, we really need to understand what is the journey that a young breast cancer patient goes through when they're getting their treatment, right? Survivorship starts from day one, from diagnosis. And that early part where they're getting treatment and then potentially ongoing treatment or maintenance treatment really influences how we approach survivorship. So the experience of that treatment journey impacts how we do surveillance, right? Surveillance is monitoring for recurrence of the cancer. We have short-term side effects that happen during the treatment, but some of those short-term side effects become long-term side effects, right? And those long-term side effects can impact a patient's ability to interact with their family, to interact with their workplace. So understanding what the potential for that is and what the experience of that is like is important. There's psychosocial impact, and psychosocial impact that can be, again, happen during the treatment and then be long-lasting. There are aspects of the treatments that we give that can impact a person's overall medical health. So, for example, some of the medicines that we give can be cardiotoxic, and that's really important for us to understand, both in terms of workup before treatment and during treatment, but then in terms of long-term monitoring in the primary care realm. And then understanding future cancer risk or recurrence, so that when a patient is with you in your clinic and it's having a symptom that doesn't seem right to you, taking that seriously, right? It might be 5 years out, it might be 6 years out, 7 years out, but understanding, hey, this has been the patient's experience, their cancer experience and their treatment journey. What do I need to pay attention to here? And then thinking about what are all of the other things that may impact their survival, or their survivorship experience, things like financial toxicity, right? So going through a treatment journey can be very expensive, can have long-lasting financial impact, time toxicity, and so we think about the amount of time that a young breast cancer patient who is in the prime of their life, they're usually sandwiched with children and, like older adults that they may be taking care of, and then are trying to take care of themselves and oftentimes don't put themselves first in that experience because of the amount of time that they have to put into this. So understanding all of this, I think, is really important and influences sort of their long-term survivorship experience. Next slide, please. So I wanted to sort of bring you into my oncologist brain, and you probably don't want to be there, but I'm going to bring you in to think about when I have a young breast cancer patient in front of me, how do I think about treatment decisions, right? So this is the oncologist perspective, sort of high level, and I want to be clear that how we make treatment decisions is paired with the patient perspective, right? So I'm sort of what I'll talk about on this slide is really about what are the factors about the breast cancer that influences treatment. But Dr. Lucking will also talk about a little bit later, like what is the patient thinking about when they're presented with all of this information? And the pairing of that together is really what then evolves into the treatment plan. So when I have a new young breast cancer patient in front of me, things that I'm looking at that influence what are the actual medicines or combinations of treatments that I use. So one is stage. So if you remember, staging is a way to understand the extent and sort of like breadth of the breast cancer. Stage 0 is what we think about like ductal or lobular carcinoma in situ. Stages 1, 2, 3, and 4 are invasive breast cancer, with 1, 2, and 3 often being potentially curable breast cancers, and stage 4 being synonymous with metastatic breast cancer, often not curable. And but in this day and age, we have so many sort of like buckets of treatment and so much innovation in the treatment of breast cancer that we're really looking oftentimes at survival in stage 4 breast cancer in the order of years, which brings its own survivorship challenges to it as well. I'm looking at histology. So under the microscope, we talked about sometimes it's non-invasive breast cancer, that's stage 0, or invasive breast cancer. It can also be ductal, lobular. We talked about inflammatory breast cancer and different types of breast cancer. Those are all important in making decisions because of the level of aggression of different histologies of breast cancer. Another thing I look at is something called receptor status. So if you look at the pathology reports, you'll see estrogen receptor positive, progesterone receptor positive or negative, HER2 positive or negative. And that's important because one, it gives us prognostic information. So for example, we know that a patient where all of these things are negative, what we call triple negative breast cancer, has a more aggressive form of breast cancer. And there are certain populations of patients that are more likely to have triple negative breast cancer. But it also indicates treatment. So for example, a woman or a man who has estrogen receptor positive breast cancer, what that means is that one of the food supplies of the cancer is estrogen, right? And so that one is a prognostic factor that tends to be a better prognosis, but two also helps us understand that there are treatments, targeted therapies that we can use to target the estrogen to sort of remove that food supply and kind of starve the cancer. So receptor status is one of the most important things that we look at. Premenopausal and postmenopausal. So again, this is sort of a division that we have in breast cancer. And most young breast cancer patients, not all, but most, are premenopausal. So this is, you're no longer having a period, and all of your FSH, LH, estradiol, all of your markers being in like the menopausal range. This is really important in terms of what is the treatment choice. We don't use the same drugs necessarily in premenopausal women and postmenopausal women if estrogen is the driver of their cancer. And it's also important because the experience that the patient goes through can be different when all of a sudden you're removing estrogen, right? And we'll talk about that a little bit more. So I've been practicing oncology, I think, for about 15 years post-fellowship now. And when I think about the advances, just the advances in cancer care, but the advances of breast cancer have really been remarkable. And one of the things that I think about in those advances is, in the beginning, when I first started practicing, we tended to, it was like more of a kitchen sink approach, right? Like we gave a lot of different treatments because we only understood so much about the biology of cancer. And over the course of 15 years, and this will continue, we are getting super savvy about the biology of breast cancer. And now what we can do is we can use, for example, different assays that really look at the genetic makeup of the cancer. So there's also the genetic makeup of the person, but the genetic makeup of the cancer, and where we can risk stratify whether a patient may be low risk, intermediate risk, or high risk of cancer recurrence. And what we've been able to do by using, really looking at these assays is now save a lot of women from having to undergo harsher treatments like chemotherapy and really reserve sort of that more escalated approach of chemotherapy and some other drugs for our higher risk patients. So I think that sort of de-escalation of treatment has been a real innovative experience for our young breast cancer patients over the past 2 decades. We talked about, Dr. Looking talked about that younger patients tend to have more genetic risk factors for breast cancer. There are lots of actually different types of genes. The ones that you may be the most familiar with are BRCA1 and BRCA2, but understanding that BRCA1 and BRCA2 are only 2 genes, and that there are actually other genes, a panel of genes that patients can get tested for that could put them at risk for different cancers. And so when you're sitting there with that patient in front of you and they are saying things like, oh, my father had a history of melanoma, and I have another person who had breast cancer, and I have breast cancer, and there's ovarian cancer and different things. like connecting those together to be like, hey, there's linkages between all these different cancers, and that might be something that we need to test you for. And then I'm also thinking about what is their eligibility for clinical trials. We should always be thinking about clinical trials, no matter whose office that they're in. Bringing up clinical trials and giving people the opportunity to access cancer innovation is so important. Next slide, please. So, we have all of those things like percolating in my brain as I'm putting together that treatment plan. And then that translates into modalities of treatment, right? And so the three sort of primary modalities of treatment are surgery, which has been around for from the days of Halsted. It has gotten a lot better, but it has been around for a long time. And radiation, and then systemic treatment. And a patient may get all three of these things, depending on like the level, maybe the stage or the level of aggression of the cancer. They may get two of these, or they may get one of these. And what that all depends on that previous slide of all those different factors, like the biology of the cancer, the patient themselves, where the cancer is located in the breast, all of those things. The idea, if we kind of like do a little deep dive, so I'm going to do a little deep dive into surgery, radiation, systemic treatment, and then I'm really going to kind of go deep into systemic treatment, because a lot of the sort of survivorship experience, there's a lot of influence based on systemic treatment. So surgery. So, right, we want to remove the cancer. If we can remove the cancer, let's do it. Let's get it out of there. So there's sort of two concepts of the way we think about that. There's breast conserving surgery or mastectomy, right? So breast conserving is removing the lump of cancer itself, and then is often used in conjunction with the radiation to kind of clean up the field there, or mastectomy, where the whole breast is removed, plus or minus radiation, depending on what is found under the microscope. We use surgery to address the lymph nodes, so that can be looking to see if there's involvement of cancer in the lymph nodes, or removing lymph nodes that have cancer. And then surgery is also breast reconstruction. So remember, like that, especially in our young breast cancer patients, that should always be, we should always be presenting the options of after surgery, what are the things we could do? So some women may say, listen, I have had enough surgeries and I don't want to do anything else. And this is how I want to be. And that's perfect. And that's right for them. Some women may say, hey, I'd like to have some shape, but I don't want to go through another surgery. And we have mastectomy bras with prostheses and other sort of physical aids to help reconstruct what a breast may look like. And then there are women who want to have an actual surgical reconstruction of that breast. There are different ways to do that. That can be with implants, or that could be using your own tissue that's moved from another part of your body, oftentimes the abdomen, to the chest wall. That can be at the time of the original surgery, or it can be done down the line. And sometimes we use surgery to relieve the symptoms of advanced cancer. Radiation. So the concept of irradiation is we're using sort of high energy rays or particles that destroy cancer cells. So if you go back to like physics and all that stuff that we were doing, unless there's a radiation oncologist on here, but all that we were doing back in college and before that, that's all that stuff coming back now. So we're destroying cancer cells with high energy rays. And it can be used after surgery to reduce the risk of cancer recurrence. But the other thing that I don't want us to forget is that can be used palliatively for symptomatic metastases. So somebody who's having, for example, bony pain because of a metastatic lesion to the bone, you can use targeted radiation to that area to help reduce the burden of, say, something like opioid use because of the pain there. And then systemic treatment. So as a medical oncologist, this is probably my favorite bucket here. So systemic treatment can be used before the surgery to shrink the tumor. We call that a neoadjuvant approach. It can be used after surgery to kill those cells that are left behind, the microscopic cells that are left behind that can't be seen by the naked eye, to reduce the recurrence risk. That we call that an adjuvant approach. And then it can be used in the metastatic setting to extend life. Next slide, please. So I'll touch upon briefly just like during the time period of surgery, for example, right? Like there's pain that happens, like surgical pain, right? That happens with surgery. But I think the other thing to remember is that it's not like you get surgery, you recover, and then you never have to think about that again, right? Like, there can be ongoing through survivorship side effects that come from that surgery, right? Because now you've introduced scar tissue into an area, so you can have ongoing tenderness. You've introduced scar tissue, so you have like inflexibility in that area compared to other tissues. So I'll have patients that'll just be like, get zingers, like where their, surgical site was, because they're moving, they're doing their stuff, but that scar tissue is not like, it's not that it's dangerous, but it's just not moving in the same way that the rest of their tissue is. It's important to understand that. It's also important to take it seriously and to understand, hey, is this something that could be cancer recurrence? Or is this scar tissue and zingers? And sometimes we don't know, and we err on the side of being careful and checking, right? And that's kind of the mindset that I always have, is we err on the side of, we always take it serious, so take the symptoms seriously and investigate. There's always the risk of infection at the surgical sites. Obviously, we do a lot of things to reduce that risk, or seromas where you can have fluid buildup, and that can be ongoing and difficult and can be going on during, the systemic treatment experience for a patient. So they're trying to get their systemic treatment, but at the same time can be getting this recurrent fluid buildup that continues to need to be drained. And then, you can get bruising and swelling at the site too. And then when I think about radiation, if you've seen the skin of somebody who's going through radiation, at the beginning of that radiation treatment, and that radiation treatment can vary like the length of time can vary anywhere between, like a few days to 6 weeks. And the amount of radiation one gets kind of determines sort of the severity of side effects. So at the more severe end, you can, it can look and feel like a very, very bad sunburn, and you can have peeling of the skin and redness, and kind of like in extreme cases, you can have that. And the radiation continues to work for like several weeks after you get your last radiation treatment. So remembering that just because they stopped radiation doesn't mean the side effects are going away. It can actually deepen before it gets better. Breast tenderness or swelling. And like radiation, although, it takes longer to get undressed than it does to get the radiation treatment, and you're getting it every day. It is a physical impact on your body, and it's very fatiguing for a patient. So remembering that this is like, an ongoing part of all of the, in addition to sort of all the other treatments that they're getting. Next slide, please. Okay, so then that puts us in that systemic therapy bucket, and that's where there's been the most innovation in terms of drug innovation over the past couple of decades. So this is kind of put together the current landscape of systemic treatment in breast cancer. So I think probably what people are the most familiar with is chemotherapy. Those are cell cycle disruptors. I won't quiz anybody today on the cell cycle, but that's what chemotherapy does. Targeted therapy. So that's basically like if chemotherapy is sort of the bomb that you throw in to kill anything that grows fast, targeted therapy is like the missile that you put in that's targeting a very specific thing in the cancer that makes the cancer grow. And there's these different types of, you'll see here, different categories of targeted therapy. And then we have different types of immunotherapy. Immunotherapy is, I wouldn't even say new anymore because it's been around for a while, but it's of the drugs we have in breast cancer is probably the newest. We'll call it immune checkpoint inhibitors, some of our monoclonal antibodies, cancer vaccines, oncolytic viruses. So all things, what's important about this is like, I often say to patients, the buckets, there are these different buckets of systemic treatment, and those buckets tend to be deep, which is why, like, even in our metastatic breast cancer, stage 4 breast cancer patients, survival can be measured on the order of years because we often have like deep buckets of things that we can draw from. Next slide, please. So let me sort of like dive into each of these. So chemotherapy. So we talked about, right, I can give chemotherapy before surgery to shrink the cancer, after surgery to reduce the risk of recurrence. In metastatic cancer, it's often used as the first line or subsequent lines of therapy. The thing about chemotherapy has been, it's been around before, Dr. Lucky and I were both born, and we've both been around a while too. So it's been around a while. It's well studied. There's decades of trial and data collection. I think in oncology, we're probably the best at prognosticating when it comes to chemotherapy, because we just have so much data around it and so much experience around it. And now there's FDA approval of chemotherapy with other agents. So you'll see in certain breast cancers, that a young woman might be getting immunotherapy with chemotherapy, right? Or targeted therapies with chemotherapy. So now we're kind of like being better about how we're targeting the biology of that breast cancer. Next slide, please. And as a primary care physician, this also may be what you're most familiar with in terms of side effects, because again, we've all been part of this experience for a long time. So, we think about the classic side effects, short-term side effects of nausea, vomiting, hair loss, bone marrow suppression. So like the red cells go down, white cells go down, platelets go down, all the kind of things that we know about. We have medicines, and I won't go into like all the different details here, right? But we have medicines to address all of those things. But then it's important, I think, to remember that some of these things then just like don't always go away, right? So like you can lose your hair, but not everybody's hair comes back, and most people's hair don't come back in the same way. There's a small percentage of people whose hair doesn't come back. And it's like a new identity, both during the treatment and then after the treatment, right? To think about. When we think about bone marrow suppression, we might think, okay, they're going to be temporarily fatigued because their red cells are going down, and those are going to recover, and they are going to recover, but the fatigue doesn't necessarily go away. One, because it's just like, oftentimes it's ongoing maintenance treatments, right? But it's not like your red cells recover and all of a sudden you feel great, right? Like the deconditioning process that goes along with the treatment of breast cancer has sort of a long-term impact. And so I think that's important to think about this. We think about long-term impacts of like brain fog, chemo brain, if you've heard about that, where people who are very high, may have been very highly functioning executive processing, find themselves not able to do the same kind of recall that they were before. And that can be very frustrating. And it's important to take that seriously as well. And it's not something to be dismissed. Next slide, please. Okay, targeted therapy. So if you remember, okay, so chemo was the bomb that we threw in, just kills anything that grows fast. So now we're sending the missile in. So we're like, okay, so for example, in breast cancer, I would say that the most common targeted therapy that people know about is targeting estrogen, right? Like the estrogen progesterone, whether we're targeting the receptor itself or like the degradation of that estrogen, or receptor, it's like usually we're manipulating estrogen. But in any of these cases, the side effects that come along with a targeted therapy depends on what is being targeted, right? So for example, we'll use in metastatic breast cancer, we may pair a targeted endocrine therapy, right? Like something that's removing the food supply with another targeted therapy that's, targeting some part of the pathway in breast cancer. And so you can, like, the thing is any organ can be impacted, right? You can get rashes. This is why I brought my dermatologist friend, Dr. Lucking, with me. So you can get all sorts of cutaneous stuff. You can get GI stuff, cardiovascular stuff, endocrine we talked about. The fatigue, everybody gets fatigue. Fatigue is everywhere. And it is, so I think you can see the difference here between this and chemotherapy is this is like a whole different set of side effects and a lot of things that fall into the primary care realm when we're talking about hypertension, lipid abnormalities, rashes, endocrine types of things that I, as an oncologist, am oftentimes working very closely with my primary care colleagues after I realized how advanced the treatment of things like diabetes has become, and it's like so hard for all of us to keep up with everything. So the lessons that I have learned in oncology management and that I hope that we can do together is that it's a team sport, right? Like there's not one person that can do all of this. And I'm working closely together with my primary care colleagues to address a lot of these side effects, that, particularly that come with the toxicities of targeted therapies. And then we have the antibody drug conjugates, which are like targeted therapy and chemotherapy mixed together. So you get the best of both worlds, where you can get some of the side effects I have here, like the, cardiovascular, for example, side effects, but then you can also get some chemo side effects like peripheral neuropathy, which may never go away, right? And can be, devastating. I had a young patient, breast cancer patient, whose profession was, she was an ice skater. She taught ice skating, she had a school, and the peripheral neuropathy was so much that she had to stop, right? Because she couldn't feel anything in her feet, right? And that was her livelihood as well. So these are, again, influence not just what's happening right at that moment, but what's going to happen, for potentially decades to come. And next slide, please. And then we have harnessing the immune system. So these are the checkpoint inhibitors. We use this in certain types of breast cancer. And you are probably going to interact with these drugs and other cancer types. So we have normally in our immune system checkpoints, safety measures, where we make sure the immune system is not like super active all the time, right? So that we're not damaging healthy tissues. Cancer learns how to evade the immune system. It develops mechanisms to do that. And so the immune checkpoint inhibitors are basically like, I explain it to the patients as like, we're boosting up or activating your immune system for a longer period of time to sort of seek and destroy cancer cells. Next slide, please. And so when we do that, when we think about like adverse events, it's like the least predictable of the drugs that we have. So, if you are boosting up your immune system, that's awesome, and it's a great way to treat cancer. It can also then sometimes the wires get crossed and your immune system ends up attacking yourself, like in an autoimmune disease. It can attack anything. So you can see here in this slide, any organ system can get attacked. It can be more mild, like diarrhea, and we have ways to manage that. Or I just had a patient for my first patient who died from autoimmune myocarditis. So, it's like that realm, and it's not predictable as to who is going to get what when we're thinking about immune-mediated side effects. So this is something that if somebody's in front of you, like working really closely, again, to me, the name of the game in all of this is like primary care physicians and oncologists are best friends, right? In order to like best treat our young breast cancer patients, we need to be like lockstep together. And there may be times where like one of us is picking up more at a given time, like we may have the ball for a longer period of time, but really we are all going to be touching that ball at some point, and working to make sure that our young breast cancer patients are not just surviving, but really living during that time period. And I think, Dr. Lecking, am I turning this back to you with the next slide?
Yes, thank you, Dr. Sivendran, for giving us the oncology perspective and taking us inside your mind and your armament. And I like to think of you blasting away all these cancers. So thank you. I wanted to just finish the presentation by presenting the cancer perspective and what that looks like before, during, and after. So when we think, like Dr. Sivendran was saying, about the cancer patient, and specifically a young adult cancer patient, and this is a very kind of a unique time in life. So there's overlapping developmental, emotional, and social aspects here, and cancer comes in and just disrupts all of it. And so looking at this emotionally and mentally, it does lead to a grief or a loss of future self, and then this uncertain future, and changes in body image and increased anxiety and depression. Also changes reproductive and hormonal health with fertility, menopause, and sexual health and intimacy challenges. And there are definitely significant financial impact, as Dr. Sivendran talked about her patient who was unable to work. But also when we think about not only career disruption, but how insurance coverage currently is tied to work. And so often patients are working through incredibly challenging and intense treatments. And that is really hard when you're balancing your finances versus your ability to live, and you want to fight for your life. So that is an incredible challenge. Also, it can be really isolating, and there is limited social support and finding other young breast cancer survivors because it is a smaller population. And some have a difficult time identifying with breast cancer groups, especially that may be more traditional or for older women or not aligned with certain viewpoints or interests. And there's also gaps in age-appropriate services and networks. And then, as we talked about, family and caregiving roles at a young age for young adults, raising young children, caring for aging family members, and this puts a strain on relationships and roles. And I put the clock here because we talked about time toxicity. This is a time in life where, as you know, you're balancing and you're juggling all the things. And then cancer comes in and you don't feel or look like yourself, might have the same capability to work or socialize or feel different than other people. And it is incredibly challenging. And because of these factors, we're going to touch upon how this looks for influencing treatment choices. But of course, there's clinical factors that Dr. Sivendran just discussed. There's also significant personal factors, how you're going to live life, like what your quality of life looks like, and tolerance for side effects, and then considerations of the future and fear of recurrence, and also cultural and social factors, family cancer experiences, because as we said, this is more likely to be genetic or hereditary. So maybe a grandmother had breast cancer, and what happened to her is going to influence how this patient views her own cancer and her own treatment. And then, of course, the economic factors, as we've discussed. And sometimes it's the patient saying, can I even get to my cancer treatment? Can I afford my cancer treatment? Who's going to take care of my kids while I'm getting the treatment? And then this will change where you're going to get the treatment, or if you're willing to do maybe a clinical trial. And then I think the other thing we don't maybe illuminate as much is that this is a time where maybe young adults are still growing in their agency, in their literacy, navigating complex medical information, and they may not have a great support care network, maybe where they've moved in young adulthood, or maybe they don't have a caregiver. They may have to return home. They may not have the finances to live on their own anymore. And so it really does change the whole reality for them. And I wanted to just illustrate this slide from a survey done between patients ages 18 to 39. This is just an illustration of the cost discrepancy in young cancer versus older adults going through cancer. This shows that 90% of younger patients responded that they had been financially impacted by their cancer diagnosis, compared to 39% of patients over the age of 40. Additionally, when you look at this, younger patients paid almost $2,500 out of pocket for prescription drugs in the past 12 months when they answered this survey. Now, in treatment, that number is significantly higher compared to those who have completed treatment. But as we just discussed, treatment is continuing on longer as a maintenance for metastatic therapy or as a maintenance to prevent recurrence because of the population itself and the aggressive nature of the cancer. This is in comparison to patients over 40 who paid approximately $800 out of pocket for prescription drugs in the 12 months prior to answering this survey. So I think this just illustrates the huge difference between older and younger patients in the cancer care world. And then when I think about patients, going on maybe after active treatment or on maintenance treatment for preventing recurrence or treating metastatic disease, there is this mind shift, right? Ongoing medical risk, because the risk is there and there is a decreased survival. And so there's more scans, imaging is very stressful. And scanxiety has a term for a reason. But lab surveillance as well, and clinic visits. And so this is all becoming the new normal for the young breast cancer patient. And as we talked about with treatment-related long-term effects, these are very significant things. Menopause, early menopause induced by medical reasons is disturbing. It's frustrating. It's all of the things. Chemotherapy-induced neuropathy, lymphedema, cardiotoxicity, brain fog. And what studies have shown is that younger patients experience these symptoms more so than older patients, 99% versus 92%. And so let's not discredit it. Sometimes just because we look like we're young and healthy doesn't necessarily mean that we're not experiencing pain. Maybe we're covering it a little bit better. But I think that that's something to think about in comparison to older patients. Also, this is occurring in a time of life with child rearing, as we said, caregiving, relationship building, and there's just overlapping crises. And these crises may not occur during the active treatment. This may occur into the maintenance treatment when patients finally have a chance to catch a breath. And as a primary care provider, you're the one noticing that. And patients might say, well, now I can't sleep, and now I can't laugh like I did, or I'm sad, or my lips and my toes feel funny, and this doesn't feel like me, and my brain is foggy. This is where the primary care provider may be the one catching these symptoms, that these are long-term sequelae from cancer treatment. So what that means for family practice providers is that there, overall is an increased number of patients living long after a cancer diagnosis. And these skills that we're trying to give you for your toolkit are going to be helpful in your practice, and it's going to be essential for you moving forward. And so I'm going to return to this wheel that we created, and we're going to guide you through this and giving you skills that will help your patients in the future. And I wanted to just make a last shout out and thank you to photographer Erica Robinson for giving us the permission to include her photography. All the women portrayed here very bravely were in a project called Under the Pencil, which portrays young adult cancer survivors in their own words in a very vulnerable stage. So you can actually read and see what it is like. And so I'm very grateful for her permission in sharing this with you all. And if we have time, we would like to open it up for some questions.
Great. Well, thank you so much, Dr. Lucking and Dr. Sivendran. I think that was absolutely wonderful as an introduction to our series. Clearly, you have a ton of expertise in this, and I think our primary care audience is really going to benefit by joining in these sessions. If people have any questions, they're welcome to put them in the Q&A or the chat. We can monitor either. I don't think we have any at the moment, but we are super happy to take your questions now or later. I'm going to post in the chat the schedule for the series, and hopefully all of you will be joining us for the rest of these through the next few months. We'll have Drs. Lucking and Sivendran, as well as some other experts from their center and others who are going to share a lot more information for you. And I also want to just thank Rebecca Book, who's our consultant, who's been putting all this together. She's been doing a great job. And thank again our sponsors, the National Association of Chronic Disease Directors and the CDC. So Rebecca, did you see any questions, any other comments before we sign off?
I am not seeing any questions. I'm just seeing lots of thank yous coming into the chat box. So thank you, everybody.
Well, again, I want to say thank you to our presenters, and hopefully we will see all of you at the next session. Have a great day.
Thank you so much.
Thank you.